Welcome to all of you. And my name is Dr. Antoinette Roth, and I'm the Medical Director of Risk Management. I'm going to take about 10 to 15 minutes to talk to you about some basic principles of risk management. Risk management can really be defined narrowly to mean really dealing with medical legal issues. For example, if you are sued within the hospital. Or risk management can be defined broadly in the context of what are things that you can do to prevent bad outcomes for your patients, staff, and self. No matter how you define risk management, it's part of one of those skills that we need to teach you while you're here in your training at all of you, because you will take these skills and build upon them, but these will be skills that you require to successfully navigate your career. I need to be really clear that we do not expect you to know how to handle these issues at this point in time in your career. So my best advice is to seek guidance. If you have a bad outcome, you get a subpoena, you have something where you feel like could be a medical legal issue, really seek guidance early on. Ask your attending or to reach out to us in risk management. We want you to see us as a resource as you navigate these complicated issues in your career. The data out there is variable, but I am a radiologist by training and I am a mammographer as well. And in my time here, I have been sued several times. And so this is something that you will need to navigate in your career. As we start the discussion, I really want you to focus on a couple basic things at this point in time. The first is you need to be aware that there are entities called Never 28 events. And what's important about this is that these Never 28 events require reporting to the state of California within 5 days. A delay in the reporting results in a daily fine to the hospital. Usually it's about $13,000 a day. So you can imagine that if we are delayed in reporting these entities, the fine builds up very quickly, okay? What do you need to do if you encounter one of these Never 28 events is you need to notify your attending, you need to submit an SI report, as patient safety just talked to you about, and call risk management. Our number is listed here. There are badge buddies that we have included hopefully in your orientation packet. If you have not received a badge buddy, please let your program director know. It should look something like this on the screen, okay? It's orange and it should be worn sort of on your badge, that way you can reference it, okay? We do not expect you to remember all of these, okay? That's why we give you the badge buddy, but I'm gonna take a couple minutes to go through each one of these so you can hear them at least once. I know that most of the people on the call here today are going to be working in the Department of Medicine, but these orientation may be used in other areas such as psychiatry, surgery, OB, and pediatrics. So I'm going to take a moment just to read these. Many of them are self-explanatory, but I'm going to focus on a couple that have caused us problems in the past. So we are going to go through 28 events that are Never 28 events. So the first is surgery or procedure performed on the wrong body part that is inconsistent with the consent. Surgery or procedure performed on the wrong patient, or the wrong surgery or procedure performed on a patient. Those are pretty self-explanatory. I've highlighted this next one in red because it's one that we have struggled with at all of you and have unfortunately received significant fines for. So retention of a foreign object after surgery or procedure, excluding objects intentionally implanted, and including objects retained in an open cavity. So I think when we talk about certain scenarios that this applied to, some are obvious. For example, in surgery, if you leave an instrument, a needle, or a lap sponge on a patient, that would be considered a retained foreign body, and we would need to report that to the state. Other examples that may not be quite as obvious is if you're putting in a central line, and when you get an X-ray to see the location, you realize that the guide wire is still in. That would be a situation where we would need to report that to the state. I think another example, again, that is less obvious is, let's pretend that you have done a surgery or procedure in which there is some packing material in, for example, the nasal cavity or the vagina. And subsequently, you removed this packing material, and you thought you removed it all, okay? But 2 weeks later, the patient presents with signs of infection, and you realize that some of that packing material was left in the patient. That would be an example of something that we would need to report to the state of California. The idea of what is reportable and is not reportable is very complicated, and there are people whose careers are dedicated to this sort of thing. So I think my best advice to you is, if unsure, just go through the process to report, and we will decide if the event actually warrants to be reportable to the state. So let's briefly move on to a couple of the other reportable, Never 28 reportable events, again, most of which are self-explanatory. As we read through these, you'll see that most of the cases resolve serious disability and death. So if you encounter serious disability and death on the floor, that is an event that you will want to tell your attending about and enter in an SI. So death or during up to 24 hours of induction of anesthesia. Death or serious disability associated with the use of a contaminated drug device or biologic. Death or serious disability associated with the use of a device other than how it is recommended. Death or serious disability associated with intravascular air embolism. An infant discharged to the wrong person. Death or serious disability associated with a patient disappearance for more than 4 hours. A patient's suicide or attempted suicide resulting in serious disability while being cared for at all of you. Unfortunately, we do have a patient population with a significant amount of mental illness, and this is not uncommon to encounter within the hospital. Death or serious disability associated with a medication error. Death or serious disability associated with a blood transfusion. A maternal death or serious disability associated with labor and delivery, and this includes within 42 days post-delivery. Death or serious disability directly related to hypoglycemia. Death or serious disability associated with the treatment of neonatal hyperbilirubinemia. Pressure ulcers, stage 3 or 4. Death or serious disability secondary to spinal manipulation. Death or serious disability associated with electric shock. Okay. Death or serious disability associated with a burn or the wrong type of gas given to the patient via a line. Death or serious disability associated with a fall. This is one that we encounter, unfortunately, not uncommonly here. Okay. Death or serious disability associated with the use of restraints. Care ordered by a provider, by someone impersonating a physician. That one I have not seen. The abduction of a patient of any age. A sexual assault of a patient. Okay. Death or significant injury of a patient or staff resulting from a physical assault. Again, unfortunately, we have issues here with patients assaulting staff. And so that would be something that we would need to report to the state of California. Okay. So again, we do not expect you to remember all these, but please be aware if you encounter serious death or disability or a retained foreign body, which is the one that we have the most problems with, please be aware that you need to escalate that. And again, how do we do that? what we need to do is we need you to require immediate notification to risk management, and we've left our number here. After hours, you can leave a message. All events should be entered through the SI system, and you need to inform your attending physician. So what's so important about SI events? Patient safety probably talked to you about. It's a way that we gather information and try to identify trends that are occurring within the hospital. But from a risk management perspective, when we talk about medical legal exposure, you need to understand that the SI is a protected document. And what do we mean when we say a protected document? It really means that it is not discoverable by subpoena from an attorney, okay? And so we need to do what we can to protect confidentiality of the SI system, okay? So the SI, you need to understand, is a safe space to talk about issues that happened, and that this modality and this medium is not discoverable by an attorney. I'd like to take a couple minutes to talk about documentation. So you will hear things like, if you don't document it, it didn't happen, okay? So documentation is one way to protect yourself, okay? I would say the other thing is that we don't want to document things that are not true or we don't know the whole situation with. So let's just talk about some general tips for minimizing liability. I would say document at the point of care whenever possible. It's maybe hard for you to imagine at this point in time, but as you expand your career, you will not remember what happened, okay, on June 19th, 2020 with every single patient that happened. And many times medical legal cases are something that emerges years later. So please take the time to document at the point of care. Be careful with the feature of copy and paste. I can't tell you how many times we have errors in the chart that are propagated forward, sometimes for years, and then have become actionable later on, okay? Document factually, and many times this is very critical when a bad event has happened. Please be careful not to assume or draw conclusions at that moment until all the facts are known. Also, we don't criticize or blame others in the chart. You will experience workflow challenges while you are an intern or resident here at All of You, and I think that this exists in every facility. The medical chart is not the place to, for example, blame radiology for a delay of care. It is not the time to criticize the nursing, okay? That can really be done in the SI system, which is a protected space. So we really want to document factually and don't get into what we call chart wars, okay? Also, don't mention risk management. If you reach out to risk management for guidance, we welcome that. But in your note, please do not say, I notified risk management. The reason for that is many attorneys, as they scrub charts and look for areas that are high risk, they will try to focus on words such as risk management. So that should be something that we do not put in the chart. So how can you reduce your liability? In the end, good communication and documentation is really the key. Your communication with your patients, your attendings, your senior residents and nursing are really critical. And please take the time to document that good communication and hard work that you put into the care of your patient. Read your documentation carefully for accuracy. Does the note convey what you really want it to convey? And do not cut and paste. You may find me reaching out to you from time to time in your training here to give you guidance on things which I feel like may expose us to medical legal risk. And I'll try to give you some feedback if I identify that. I would like to take just a couple minutes to talk about consent. Consent is really a skill, and I encourage every one of you to really push your upper level residents or attendings to show you how to properly consent. Many times we treat the consent as a lower tiered skill, but really the consent is probably the most fundamental communication and documentation that can exist between the doctor and patient prior to doing a procedure or surgery, okay? So please work on this and encourage your upper level residents and attendings to provide guidance and teaching on this issue. So who can consent? Any adult patient with capacity, a surrogate decision maker, or someone that's appointed an advanced healthcare directive or power of attorney. I think those situations are quite obvious. But other people can also consent if by chance the patient is unable to consent for themselves. A spouse or domestic partner, an adult child, siblings, grandparents, nieces or nephews, or many times at all of you, a close friend who knows the patient's wishes. If you're in doubt and you have questions about consent, risk management is always available to help you, okay? So please reach out to us and see us as a resource. A conservator. So unfortunately, we have some patients who do not have capacity and are wards of the state for one reason or the other, and they will have a court-appointed surrogate to make healthcare decisions. Emergency exception. So this applies to many times people who are working in the emergency room or an emergency situation when a patient lacks capacity and they really need emergent treatment. In those cases, care can be performed without consent. So if a patient needs immediate services that are required, okay, or immediate diagnosis. Obviously, if a patient comes in with a gunshot wound, they are not able to give consent for all the treatment that may be required, that would meet the criteria for an emergency exception. But let's say, for example, you encounter a different situation. This may be a case on the medicine floors where a patient does not have capacity. And that may be because of mental illness. It may be for numerous reasons. They do not have a surrogate or relative to sign. For example, there is no family, maybe the patient is homeless. And the procedure is not emergent. This is not a life or death situation that needs immediate treatment. What should you do? You need to understand that there are resources here at all of you through the Bioethics Committee and Risk Management. We call these unrepresented patients. And so basically what you need to do is you need to consult Risk Management, and we will try to get a group together to help you consent the patient legally through different processes that may not be through one of these other means, okay? I want to make sure that you know there's no such thing as a two-person consent. So, you know, let's say a patient needs a routine lumbar puncture that can be done in the next 5 days. You guys aren't concerned about infection. Maybe you're trying to rule out to look for multiple sclerosis or something. And you guys can't find anybody to consent the patient, and the patient does not have capacity. I want to make sure that you understand that you cannot have two physicians just sign and still say that you can do the procedure. You need to go through the process of getting an unrepresented patient consult. All you have to do is call Risk Management, and we will organize and we'll try to get you the appropriate consent for your patient. The last topic that I'd like to touch on briefly is the concept of disclosure. Unfortunately, bad events are going to happen, okay? Or unanticipated events are going to happen, okay? And how do you address those? So, first of all, what is an unanticipated outcome? I think this is pretty self-explanatory. It's an outcome that was not expected to occur, although there may have been awareness that it's possible. There's a surgical procedure that's happening and the aorta was nicked, okay? You were performing an internal jugular line placement and something happened, I should say a subclavian line placement maybe, and we accidentally caused a pneumothorax. Complications of care exist. Sometimes they are preventable and sometimes they are not preventable. But we need to let the patients know that these events occurred, okay? So the idea of disclosure is to ensure that patients are informed of an unanticipated outcome, okay? It's really the job of the physician to disclose unanticipated outcomes to the patient and the family. You can imagine that these conversations can be very delicate. So again, I would encourage you to seek guidance on these conversations from your upper levels to your attending when things really have an unanticipated outcome. The physician needs to clearly explain the outcome, what happened, and what are the effects or consequences. And sometimes you don't know. And disclosure needs to be made in a timely manner. And then you have to document your disclosure. It's not just enough to have a conversation. You have to document in a chart, and it's a very short documentation. Usually just the time and the date, the list of the names and the relationships of the people who were there, and any documentation of things that were discussed, and a brief factually based description of the unanticipated outcome. Again, we don't want to draw conclusions here because many times at this phase, we don't know. And so many times the disclosure is only 3 to 4 sentences long. And again, I want you to see risk management as someone who can guide you through this process. If your attending wants guidance or you need guidance, please see us as a resource. So again, welcome. I know that that's a lot of heavy information and sort of doom and gloom as you just start your professional career, but please reach out to us. We are happy to help you at any time. Thank you so much.